Hello, everyone, and welcome to the second episode of Oncology Watch, brought to you by Oncology Me. My name is Hazem ElMansy. I'm a lecturer of clinical oncology in Alexandria University in Egypt. Today, we are honored to have Professor Shaheena Dawood. Professor Shaheena is an adjunct clinical professor in Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, in the United Arab Emirates. And with our professor, Mohsen Mokhtar, professor of clinical oncology in Qasr Al Aini School of Medicine in Cairo University. We will wait for 1 minute for all to join, then we will start. So, Dr. Mohsen, Dr. Shaheena, today we'll be speaking about optimizing the adjuvant endocrine therapy for the early breast cancer. So do you see this is a hot topics these days? We have new data coming in from using CDK4/6 and the duration of treatment.
I think.
What do you think, Shaheena?
Yeah. Thank you, Dr. Mohsen. I think at least from my end, I think in the last decade, if anyone were to ask me that question, I'd say this is the hottest topic that we have. There's been an explosion of data that has been both interesting for oncologists as well as confusing for oncologists, because we have so much information. We have so many different therapeutic modalities, both old and new, that as oncologists, we're trying to find the best optimal therapeutic strategy for our patients. So in a way, it's good that we have so many options for our patients, but I think the confusing thing, and I think that's going to be the multi-million-dollar question going forward in the next decade. And I don't know what you think, Dr. Mohsen. I think it'll be trying to optimize the right cocktail of medications for that right patient to give them the best possible prognostic outcome.
I think what we tend to do, Shaheena, as well, is forget how important hormonal therapy is. I mean, it's 70% of the patients, and it has made a difference. And if you look at the data from hormonal therapy, as per se, without any of the targeted therapy, in its own effect has succeeded anything from chemotherapy. I think it's just topped by anti-HER2 therapy, but anything else, I think hormonal therapy is something that we take lightly, and unfortunately in our region as well, patients are not adherent to what we tell them with hormonal therapy a lot. I think that's another thing that you need to really discuss with your patient when we're talking about hormonal therapy.
Absolutely agree.
So,
I think that, like you said, one of the first therapeutic strategies in the treatment of breast cancer has been manipulation of hormones. And over time, we've seen so many different therapeutic modalities come up in terms of blocking hormones, both in the early and the metastatic setting. And you're right, it's sort of been put in the back burner with all the newer targeted agents, such as anti-HER2 therapy, immunotherapy, but we've gone back to the basics. We've added to those basics, and now we've just had an explosion of data, and these patients do very well. But like you said, right treatment for the right patient and getting them to actually adhere to the medication is also very important.
Yeah. And Shaheena, before we get into something, because this has obviously been watched by a lot of junior staff. Is ER positive as equivalent as just a PR positive patient? Because I think that's another thing we need to get clear. PR positive patients are not ER positive patients.
No, absolutely. If you have a patient that's ER negative, PR positive, I think the first thing that you need to do is go back to your pathologist and see if there's a technical error or not. So that's really important. And they are a very small group of patients that are ER negative, PR positive, and you can't ignore them. You still have to treat them, but it's not the same as being ER positive. So I think it's very important, especially for those junior members out there, and those in trainee, that if you get a patient that's ER negative, PR positive, go back to your pathologist. It might be a technical error that you need to correct.
And the ER positivity is that score of 3 out of 8 that you get and above, or would you like to? Obviously, you'd like to see it higher, but I mean, is a 3 over 8 an effective thing to do? I think.
If you look at the latest guidelines, both from St. Gallen and other international guidelines as well, they all state the same thing: 1% and above, treat them with adjuvant endocrine therapy. However, I think the confusion is going to come in those patients with low ER positivity, like you said, where they
Yeah.
typically behave like a triple neg.
Yeah.
And then you wonder whether you need to give them adjuvant immunotherapy rather than adjuvant endocrine therapy. And those are the patients that you really need to discuss in your MDT, because you're never going to have a clinical trial that's going to address them. We have two large retrospective studies, from one from Germany, one from Italy, that's actually shown that those patients with low ER positivity, they behave like triple negative breast cancer. So I think each of those patients, their treatment modality has to be individualized. And those are the patients where you definitely need to discuss them in the MDT.
So thank you, Dr. Shaheena. I'll take some of your words, because today we will focus on the basics. We will focus on the hormonal treatments that we used for a very long time to use, and we will not touch the data from the CDK4/6 inhibitors or even the PARP inhibitors. And we will keep this to the next episode, because this is a very long discussion that takes its time. So I think we should start the questions right now. And for almost 30 years, the gold standard of adjuvant endocrine treatment was 5 years of adjuvant tamoxifen. This was based on the B14 trial and the Oxford meta-analysis that showed about 40% reduction in the risk of recurrence and 30% reduction in the risk of death compared to no adjuvant hormonal treatment. My first question to Dr. Mohsen: today in 2023, is there a patient where you can prescribe only 5 years of adjuvant tamoxifen?
Hazem, and I hope Shaheena agrees with me. Yes, it is. There would be a couple of patients that I would do that, especially if they're very early in situ T1 and 0 diseases, especially in a premenopausal patient, also in some postmenopausal patients. Some of them might be intolerant to aromatase inhibitors, patients that come in with already severe osteoporosis, joint disorders. Some of our patients, because of their weight, sometimes come in with that, especially knee problems. And this causes a baseline chronic musculoskeletal pains. Maybe these patients you can avoid using an aromatase inhibitor, and tamoxifen could do the job, especially if they're in the early setting or early patients. In such patients, I can still recommend 5 years of tamoxifen only.
Dr. Shaheena, would you like to comment on this?
No, I completely agree with Dr. Mohsen. I think there's an opportunity to de-escalate, and I think there's an opportunity to escalate. This year at San Antonio, we did see a trial that actually looked at de-escalating tamoxifen in those patients with in situ disease, where they're actually reducing the dose of tamoxifen from your typical 20 milligrams to your 10 milligrams, and even 5 milligrams may be sufficient for those patients. And definitely 5 years is the maximum that I would give it in situ disease. I think in patients who have actual invasive disease, and you've seen this from the Early Breast Cancer Trialist Collaborative Group, that even in those very, very small tumors or those node negative tumors, there is always that risk of long-term recurrence. Yet we don't know who are those patients that are really going to benefit from more than 5 years of tamoxifen, because the ATLAS and the ATOM trial really encompassed everyone. So I think at the end of 5 years, in those really low-risk cohort of patients, if my patient is completely asymptomatic and they want to continue, I'll let them continue. But if they've got symptoms, like the way Dr. Mohsen says, you have to have that discussion with them. You have to give them the data of ATLAS and ATOM. The benefit is actually quite small, and there is a carryover effect of tamoxifen. So I think you have to have that open discussion with your patient. And I'd be very comfortable actually stopping it at 5 years in those very, very small group of patients, but you still need to have that open discussion with them.
So in Egypt, and I think in many other countries in the Middle East, we are seeing increasing number of breast cancer patients presenting with the malignancy before the menopause. So let's focus for a minute on the premenopausal woman. And my question to Dr. Shaheena: in which patient would you use ovarian function suppression? And the important question as well is, for how long?
So I completely agree with you. In our part of the world, the Middle East, we're seeing a lot younger patients. I know when I was in the US, I used to get very excited to see a young patient. Now I get very excited seeing an older patient, because most of our patients are below the age of 50. In fact, I went back to my own data, and I think the median age of diagnosis of breast cancer was anywhere between 40 to 45, which is, I think, what you're seeing as well, Dr. Mohsen, in your cohort. So the question is, which one of these, which group of premenopausal patients requires ovarian function suppression if they have an ER positive early stage disease? Well, the first thing is they all need endocrine therapy. They all need adjuvant endocrine therapy. And this could be either with tamoxifen or an aromatase inhibitor if you're adding ovarian function suppression. So who needs ovarian function suppression? Well, based on the SOFT in the text trial, if you're which enrolled patients who were premenopausal, and they all had their ovaries suppressed with GnRH analog, and they were randomized to get either tamoxifen or ovarian and plus ovarian function suppression, or tamoxifen alone, or an aromatase inhibitor plus ovarian function suppression, you really saw the benefit of adding ovarian function suppression in those premenopausal women who are at high enough risk to warrant getting chemotherapy. So if you have a high risk premenopausal woman, and you could define high risk by their lymph node positivity, because you know they need chemotherapy at that point, or if they're lymph node negative and they have a high oncotype recurrence score, either in the high intermediate or in the high risk category, these are the patients that require ovarian function suppression with either tamoxifen or an aromatase inhibitor. Now, how long will I give ovarian function suppression? If you look at SOFT and text, the standard was to give it for 5 years, but you do have some interesting anecdotal data. Well, I wouldn't call it anecdotal, it's prospective, but we haven't really all incorporated it, is from the ASTRA trial that used only 2 years of ovarian function suppression. In my practice, when I'm counseling these women, I tell them the standard is 5 years of ovarian function suppression. But at the end of 2 years, if I find they're not able to tolerate it, and a lot of these premenopausal women, they aren't able to tolerate it, I say at least a minimum of 2 years based on the results of the ASTRA trial. Dr. Mohsen, what are your thoughts here?
Exactly the same, Shaheena. I start off by telling them it's a minimum of 2 years, but if we get to the 5 years, that would be better. And I just add on, maybe in a patient that is 45 and above, that's not a patient I do the ovarian function suppression in, but anything less than that, that's where I offer ovarian function suppression. So. I don't know about your thoughts on checking on the estradiol level for these patients on ovarian function suppression or prior to ovarian function suppression after you've given chemo to them, those patients that are over 45. Sometimes they go clearly into menopause on their own, and maybe I could wait if the patient starts to get her menstrual cycle again and she's very high risk, then I could offer ovarian function suppression. But anyone that's young, yes, I do, and I start off by telling them it's 2 years and we could extend to 5 years. But I will tell you that a good 50% of the patients will stop at 2 years and they don't want to continue beyond those 2 years. And I think the ASTRA trial was sort of reassuring that you can sort of do that in some patients.
So we have a question posted about this topic actually. It says that ovarian function suppressions and aromatase inhibitors are associated with great deal of side effects, like the hot flushes, the bone pains, arthralgia, or even sometimes sleep disorders and depression. Dr. Mohsen, what would you do in high-risk patients who have poor tolerance to the ovarian function suppression?
Look, I think first of all, it's important to tell the patients that they might have some of these symptoms, because when they do have them and you've already told them about them, it's not as bad as when they start getting them without you having told them. So a good portion of these patients, as I said, are non-compliant to hormone treatment, mainly because of the adverse events. So if you look at the SOFT data, 1 in every 5 patients, so that's around 20%, had to stop the ovarian function suppression. This could be a consideration. If you try and give some pharmacological measures that can be used, such as bone-modifying agents to prevent the bone loss, or an antidepressant to control things like altered mood, sleep disorders, flushes. But again, as I said, in many patients, we have to take the decision whether or not to de-escalate and start back on tamoxifen alone. There was, as I said, an interesting study from the Astra trial, which randomized these patients to tamoxifen alone versus tamoxifen plus only 2 years of an LHRH agonist. I think it showed the disease-free survival as well as the overall survival with the addition of the ovarian function suppression just for 2 years. So I will mandate for my patients to try and receive the 2 years with the proper measures. But after 2 years, if the patient still wants to get off the ovarian function suppression, and especially in those patients that are premenopausal, the hot flushes really make them bad-tempered, and maybe some of them are still in their early marriage years, and they don't want to get into all those fights with their husbands. Sometimes I will stop after 2 years of an LHRH agonist.
I totally agree with this approach, and I think doing all the possible measures to keep our patients tolerant and compliant to the endocrine therapy of utmost importance, actually. So let's switch to the postmenopausal patients, where there is a consensus on adding aromatase inhibitors to the adjuvant treatment. And here I will address the next question to Professor Shaheena. Which strategy of introducing aromatase inhibitors do you prefer? Is it the upfront aromatase inhibitors for 5 years, or the sequential strategy where you start with the tamoxifen and then switch to the aromatase inhibitors?
So I have to admit, when you look at the data, aromatase inhibitor in a postmenopausal woman does have trumps tamoxifen in a postmenopausal woman in terms of risk reduction, although an overall survival advantage has never actually been shown with the addition of aromatase inhibitor compared to tamoxifen. Having said that, whenever I have a patient that is postmenopausal and high risk, there's no question in my mind, I will start off with an aromatase inhibitor. But when I have a postmenopausal woman who is low risk, I give them the choice. I tend to use more of an aromatase inhibitor, I have to admit, but it's the type of patient that you see in front of you. If you've got like I recently had an 85-year-old woman with obviously postmenopausal ER-positive breast cancer with osteoporosis and already has arthritis. Sort of subjecting this woman to an aromatase inhibitor didn't make sense, especially since it was a very low risk disease. And so I started her off on tamoxifen. But if I have a younger 60-year-old woman, we discuss it. We talk about all the potential side effects. I always say an aromatase inhibitor has 3 main side effects, irrespective of your age. 1 is exacerbation of menopausal symptoms, 2 is exacerbation or induction of osteoporosis, and 3 is significant joint pains. If they're willing to take that on, we do start with an aromatase inhibitor. If they're unable to tolerate it, I'm very happy to switch over to tamoxifen. So I start with an aromatase inhibitor, but if they're unable to tolerate, I will start with tamoxifen first, and then if they're high risk, I will switch over to an aromatase inhibitor at some point.
Thank you for this very clear answer. So what about extending the duration of the adjuvant treatment therapy? Since the results of the MA17 study showing a disease-free survival improvement and even a trend for the overall survival in the node-positive patients, by extending the treatment beyond the 5 years became more appealing in the practice. Dr. Mohsen, which patient do you advise to extend before 5 years of adjuvant hormonal treatment?
We don't have a clear answer for that one. I think according to the Oxford group, around half of the breast cancer recurrences occurred after 5 years. Those are the hormone receptor positive breast cancers. And the cumulative risk rises with your higher T and N stages and gets up to 40 to 50% with heavily nodal involvement. Taking that into consideration, I think adjuvant therapy beyond 5 years for any patient that I have given chemotherapy for, those are the node-positive patients, and anyone that I've tried to have an ovarian function suppression, I think they would also benefit from beyond 5 years up to 7 years at least. And for patients with large tumors or high grade or even node that are node negative, if they've got a high grade or high Ki67, patients that we hadn't started on something like the Monarch E, those are the patients I would have pushed for at least 7 years of adjuvant hormonal therapy. Shaheena, what do you think?
I think there are really two parts to this question. Number one, who requires extended adjuvant endocrine therapy? And two, if you're going to give extended adjuvant endocrine therapy, how long are you going to give adjuvant extended endocrine therapy to? So the first part of the question is who to give adjuvant extended endocrine therapy to. And I think this part of the question has already been alluded to right at the very beginning when you were asked the question, would you give everyone? The simple answer is from the early breast cancer trialist group, if you really strictly go by the data, everyone actually benefits from extended because patients with hormone receptor positive disease always have a long-term risk of recurrence. But if you have that really, really low risk group of patients, you're going to try and avoid it because the benefit of adding, say, extended tamoxifen or giving extended aromatase inhibitor and having all the added side effects is not going to be that much. So it's obviously you have to pick and choose your low risk patients and then obviously divide them based on your high risk patients who would benefit. High risk patients include those with high oncotype DX and your premenopausal node negative or your node positive patients who would benefit from extended adjuvant endocrine therapy or any of the high risk features. So then how long do you give adjuvant endocrine therapy? And I think the oncology community is completely confused about this. If you look at Atlas and Atom, 10 years of tamoxifen therapy. If you look at all the different trials that have been looked at for aromatase inhibitor, at one point, and I'm sure Dr. Mohsen, you'll agree with me, we all said 5 years tamoxifen, 5 years aromatase inhibitor. That's 10 years. Or if we've started aromatase inhibitor from the very beginning, we could potentially go on to give 5 years of tamoxifen later on. So you're still giving 10 years. Now the questions come up. You could potentially just give 7 years of an aromatase inhibitor if you start right from the very beginning, and that could be enough. I think the consensus is you need extended therapy, but how long that extended therapy is, I think you need to individualize it based on what your patient's experiencing, the side effects, and of course, what the risk factors are. My premenopausal women who are really high risk that I give adjuvant ovarian function suppression plus an aromatase inhibitor, if they manage to get through 5 years of endocrine therapy, after that, I'll put them on tamoxifen because their risk is way too high. So you need to individualize therapy. Like I said right at the very beginning, we have so much data now. It's all about individualizing therapy.
I think that's the clear message from Shaheena. You really need to individualize your patient. But again, any patient that has had chemo or has had an ovarian function suppression is probably the candidate to go for an extended adjuvant therapy.
Absolutely. I also would like to add that any patient that you deem high enough risk to fit the Monarch E trial, and you're going to give adjuvant to BEMA, you better give adjuvant extended endocrine therapy to that patient as well.
So Dr. Shaheena, you already answered my next question, which was about the duration of treatment. Would you prefer the 7 or 8 years or up to the 10 years? And I think you've already touched on this. So it's an individualized decision that you have for every patient. So I have a final question. It is shown in almost all the aromatase inhibitor studies a significant affection of the bone mineral density and the fracture risk when using the aromatase inhibitors. How do you position the bone modifying agents in the post-menopausal women receiving the aromatase inhibitors? I mean, the zoledronic acid or the denosumab. Would you start it at the beginning of the adjuvant aromatase inhibitors, or would you wait and monitor the bone mineral density before starting the bone modifying agents?
I'll give you a heads up on that, Hazem. If you do bone mineral density for any patient in our region or vitamin D, you'll find they're all already osteopenic or getting into osteoporosis, especially if they're postmenopausal. I think you need to start off from the very beginning. Give it every 6 months. I start with after the first 6 months, I'm giving it. The question is, Do you stop it after 2 years because they are still osteopenic? What do you do, Shaheena? Do you continue for the 5 years every 6 months?
So, when I'm discussing adjuvant bisphosphonate with my patients, number one, Hazem, we don't give it to only postmenopausal women. We're giving it to high-risk premenopausal women that we're doing ovarian function suppression for as well. And I tell my patients very clearly, I don't care about their bone. I actually care about their cancer. The bones is, adding bone health is an added benefit. You're giving the bisphosphonate to reduce the risk of the cancer coming back, clearly shown by the early breast cancer trialist collaborative group. So give it as early as possible. Why would I want to give it late? The data suggests that we should be giving it once every 6 months for 3 years. Now, very, very clear, Dr. Mohsen has put up a very important point. Post that time, if your patient is osteopenic, are you going to continue adjuvant bisphosphonate? There's no harm in doing that. That's what our rheumatologists would do. The only thing that I do in my clinic is I will consult with my rheumatologist just to be sure that it's okay to continue. Because sometimes when you continue adjuvant or when you continue bisphosphonates or rank ligand inhibitors beyond a certain period of time, you can actually get abnormal fractures secondary to these medications. So I think from an oncology perspective, I'm very comfortable giving it for 2 to 3 years, just like Dr. Mohsen says. Beyond that, I have to admit, I tend to consult with the rheumatologist. I send my patients to the rheumatologist to continue that because I've had patients with abnormal fractures beyond a certain point, which obviously we won't be able to take care of.
So you would use the bone modifying agents with starting the aromatase inhibitors, and you will keep on monitoring the bone mineral density.
Let me correct you there. The guidelines and the data suggest that you can give it even to patients who are on tamoxifen plus ovarian function suppression or tamoxifen and they're still menopaused. So it's not only for those patients who are on aromatase inhibitor, it's for those patients with, who are in a menopausal state, either biochemically with ovarian function suppression or who are actually post-menopausal. If you look at the guidelines, they also suggest that you can give it in patients with triple negative breast cancer as well. So it's not only restricted to ER positive breast cancer. So it's not only for patients who are on aromatase inhibitor.
Hazem, I'll admit that I've also given it to patients who are osteopenic and have had chemo, because chemotherapy does cause osteopenia. So even if your patient is HER2 positive and has osteopenia, I think she would benefit from a bone modifying agent.
Absolutely. These women, if you look at the data and if you look at the guidelines, you render your women menopaused, you give it to them. And I, like Dr. Mohsen, even if my patients are not rendered menopause, they've gotten chemotherapy for some reason or the other, and they're osteopenic, you can still give it to them. But obviously the benefit is different in that end. So you're talking about risk reduction for cancer versus maintaining bone health. Maintenance of bone health should not only be with aromatase inhibitors. Yes, aromatase inhibitors causes osteoporosis, and that's one aspect. But then you've got chemotherapy that also causes osteoporosis and osteopenia. And then you've got the benefit of these agents in terms of risk reduction.
Okay, so I can understand that you're using the bone modifying agents in any patient who is postmenopausal, even by age, or you prescribed ovarian function suppression for any patients who received chemotherapy, even the patients who were prescribed corticosteroids for a long time, or usage even with the chemotherapy. This adds to their osteopenia or even the osteoporosis. So all these patients would benefit from the aromatase inhibitors, and you continue for 2 to 3 years, and after that you talk to your rheumatologist or orthopedic for continuing the patient's ovarian function, bone modifying agents, and you keep on testing or monitoring the bone mineral density every year. That's what you do, or it's less than every year?
100%. I do.
Yeah.
I do.
With the mammography, you do it with the mammography. I think it's standard to do it with the mammography.
Okay.
And I think in our part of the world, Dr. Mohsen, I think everyone's osteopenic or osteoporotic.
That's another issue, that a lot of our patients are already osteopenic in our region of the world, even though we have too much sun. But no.
Yeah.
Yes.
Yes. So here we come to the end of our Oncology Watch second episode, brought to you by Oncology Me. Before we close, I have to say again that we chose not to touch the data of the CDK4/6 inhibitors or even the PARP inhibitors in today's discussion, because we are looking forward for a dedicated episode for this discussion in the near future, inshallah. I would like to thank Professor Shaheena Dawood, who was joining us from Dubai in the United Arab Emirates, and Professor Dr. Mohsen Mokhtar, joining us from Cairo, Egypt, and I am from Alexandria. So we have 3 cities involved in this meeting. Thank you, Dr. Shaheena and Dr. Mohsen, for giving us your time and sharing your experiences. And thank you everyone for attending, and I hope to see you again in the third episode and the following episodes of Oncology Me, brought to you by Oncology Watch, brought to you by Oncology Me. Thank you, Dr. Mohsen. Thank you, Dr. Shaheena.
Thank
you,
you.
Hazem.